with, can you tell me a little bit about you and your position?
So I'm Deputy Secretary for Medical Assistance, which is essentially the Medicaid Director for North Carolina. So I have responsibility for leadership of the team that runs the Medicaid program in North Carolina.
Can you explain what Medicaid reform means?
Yeah, Medicaid reform is been going on, or the conversation about Medicaid reform, for the past 3 years in North Carolina. It's been a long process by which the General Assembly, the administration have talked about how do we assure that Medicaid is, one, cost predictable, make sure that it is high quality, and that it's sustainable for the long term. In the past legislative session, the General Assembly and the governor agreed upon a proposal to go forward, which would create a capitated managed care system for Medicaid. It would allow for 3 commercial plans to work statewide, and then 12, potentially 10, provider-led entities across the state in 6 separate regions. It is mainly about the physical health side, but it has great interaction with the behavioral health and IDD system. And it's designed to do just what the legislature wanted. Make sure that we have a predictable Medicaid program going forward, but improve the quality of care for people that receive services through Medicaid. So in North Carolina, it's about 1.9 million people that receive some sort of benefit through Medicaid, and about a $13.5 billion budget.
Can you give us some more detail about how North Carolina is approaching Medicaid reform, and maybe touch on the time frame?
The most important thing to know about what this is that, so we talked about cost predictability, but clearly there was no indication of cost reduction. So I want to be clear about this. It's not an opportunity to cut the Medicaid program, but rather to make it a more effective program as we go forward. We believe that means building upon what works in North Carolina, the best of what we have. It also means looking at what other states have done across the country and trying to enhance what we do, taking the best from what they've done. But mostly it means creating a North Carolina solution for Medicaid. So what we see is that we want to build upon the triple aim, which is really about patient engagement or individual engagement. It's about cost containment as you go forward. It's about how do we create better high quality services for people and high quality outcomes. And then we've added a quadruple aim for this, which is to really help providers make this transformation. Because what we know is that in the Medicaid program, if you don't have quality providers, then everything else we try to achieve doesn't work. And so we have great providers in North Carolina right now. We want to move them toward a higher level of service and support. Some of the things that I think are really important for the IDD and mental health community, and frankly for everybody, is that we make a conscious shift from calling things patient-centered to person-centered, which is a value that the system for people with mental illness and developmental disabilities has had for years. And it's really about that. It's about how do we create a Medicaid program that thinks of you and I as people first, knowing that in our life we're patients a very small part of the time. And when we think that way, how do we engage the entire community in supporting health outcomes for individuals? So I often think about it as when I go to the doctor, I'm a patient for that really short period of time. But if I'm really going to have better health, I have to do a whole bunch of things outside of what's happening in the physician's office. And if our Medicaid program can drive those by aligning our payment systems to those kinds of outcomes that we're trying to achieve, then I think we'll see a much better outcome for North Carolina's citizens who are on a Medicaid program. It's as simple as thinking about I have heart disease, and so if I go to my cardiologist, he'll tell me all the things I'm supposed to do and to improve my health. Part of that's take my meds on time, and that's the easy part. The other thing, exercise, eat right, do all those things that aren't as easy. And if you think about it, for our Medicaid population, it'd be really nice if we could align the payment so those things became easier. So if we could pay for nutrition support, if we could pay for other things that would really help people make those goals that they need to improve their quality of life, then we'll do a better job. So that's essentially what we're trying to achieve. Make sure those things are available for people as go forward. We'll still base it on primary care physicians and those primary care providers. We'll have a integration with the behavioral health system. As you know, right now the LME MCO system is not included in this new 1115 waiver, but we'll have outcomes that cross over from those systems, and we'll do more things to encourage high quality and really positive health outcomes for all people in the Medicaid system. This is going to take time. It's not something that's going to happen overnight. So the legislation requires us to submit an 1115 waiver, which is the most complicated of waivers that you submit to CMS. CMS doesn't have to respond in any period of time. So we assume, and I think it's a reasonable assumption, that that's going to take time. It's what other states have looked at as somewhere around 18 months before approval. So if we submit June 1st, which is the deadline we have to, let's move it to July 1st of 16. We'll submit June 1st. We'll hit those timelines, but just for ease. So we're talking about 18 months from there. We're now in January of 2018 when we would expect to have approval from CMS. Once we have approval, we have 18 months to stand up these new managed care plans to support the Medicaid program before we go live. So we really are talking about a 36-month, 3-year period from today before we actually begin this new plan going forward.
There's been a lot of talk about different types of waiver. Can you explain to me a little bit about what the 1115 demonstration waiver is and kind of what it requires of the state?
So 1115 is a demonstration waiver, and as you know, waivers are really just waiving rules that CMS has for certain programs. It allows us to do managed care, but you can do managed care in other authorities under Medicaid, including 1915B, which we have right now for our LME MCO system. The 1115 requires us to demonstrate things, to prove to CMS that the things that we're doing are going to improve health quality for people and change the trajectory of our costs as we go forward. So for us, a couple of things that we want to prove to CMS, there are multiple ones, but prove the two top ones I would say is one is that by having provider-led entities, which are these regional entities, which are North Carolina-based organizations that could be health systems, they could be doctors banding together, combined with commercial plans, regular insurance plans, will improve health outcomes because of the competition between the two. They'll work together, but they'll compete in terms of creating better outcomes for people. So by holding them accountable for those outcomes, we think will improve health. So that's one of the things we'll try to prove. The other is we believe that our person-centered health community, which is really this next level up from what we currently have in our patient-centered medical homes, is to absolutely prove to CMS that by thinking about those things upstream, as we really believe about health outcomes, that will change the health of the Medicaid population going forward. And then we have multiple things inside of it around behavioral health integration, but really a lot of it has to do with what can we do on the medical side that we haven't thought about in the past. One of the things that we know that the IDD community was really interested in was the IDD health home. So an opportunity to think about that inside this new waiver, the chance for people that are supporting individuals with developmental disability to take a more robust role in their health outcomes and be rewarded for that if they do well, and certainly if there are penalties if we don't, but to reward people for paying attention to those things is going forward. So it's a much more stringent requirement than the other waiver authorities that you can do managed care, but it is one in which we think is absolutely necessary for North Carolina if we're going to really improve health for our citizens.
What is the best way for people with disabilities to advocate during this Medicaid privatization process for the next few months and then also for the next few years?
Yes, and one thing I would mention is that so there's a lot of talk about privatization in Medicaid. And to be real clear is that the state does not give up any of its responsibilities in this effort. So we'll use private organizations to manage the Medicaid population, but the state is still responsible. So I want to make, because that really does help think about how's the best way to interact as we're going forward. So first of all, we have a series of public hearings that are starting Wednesday of this week. First one in Raleigh, and then I'm sure you'll post where all the other ones are. That is absolutely the first place where people can make an impact. Now, I want to be clear, people made an impact prior to that. So if you look at the draft waiver as we go forward, and you see some of the things inside of it, I think what you'll see is reflected about what North Carolina citizens said to us about what should happen, because we met with lots of people as we went through that process. But the public hearing is a chance for us to understand whether or not we got it right, if you will, from what we heard from people in North Carolina. Tell us what's good about it. Tell us what you think we missed. Tell us what your hopes and dreams are about the future for the Medicaid program for you as an individual. So that's the place, and they really are hearings. They're not going to be debates. They're not all these other things. It's a chance for people to stand up a short period of time, but tell us that. The other opportunity is to go on a website and absolutely send written comments. Now, it's harder for some people to do that, easier for others to do it. So whatever method makes the most sense, we encourage people to do that and use both if that's an opportunity. The other thing that'll happen, and 1115 is a little bit different, then I'll talk about specific things, is that CMS will open up a public comment period also. So once we've finished this in North Carolina, people have the opportunity to write to CMS and say what they think about it. So that's another avenue for individuals to be involved. But we don't stop there, because once we submit the waiver, that's not the end. Submitting a waiver, frankly, is the beginning. We'll negotiate with CMS for a long period of time. And our expectation is that we'll be engaging all communities as we go forward about what is the best way for us to implement this. It's the best way to integrate the physical health and the behavioral health, substance use, and DD communities into the broader plan. And what does the long-term future look like? So, for instance, if you're someone with an intellectual developmental disability or a family member, you might want to talk about what are those real support needs that people have, and frankly, how does that interaction with a physician work for you today, and what would you like to see long-term in North Carolina to make that better for you going forward? Somebody with mental health needs or an advocate for people with mental illness really ought to talk about what are those really key components of a strong behavioral health system that support people, one, when prior to needing the specialty system, which is the LME system, but what happens in the LME MCO system to really improve quality of life for that individual? How do we manage that as we're going forward? But I really would emphasize that a lot of things we can do in the traditional system, in the physical health system, is something that we're real interested in. Same thing in substance use. We have a big initiative in North Carolina with mental health and substance use through the governor's task force, and we recognize that some of those recommendations ought to be the recommendations that are inside of our reform plan. So as people are seeing that effort going forward, as if you have a substance use advocacy organization or folks from that side, tell us what would make the most difference, especially again in preventative things. That's what we're really looking for. How can we do things today that 20 years from now will make a difference, not just what makes a difference tomorrow? So that opportunity to continue that conversation. Our belief is that we'll always talk to constituents, but in terms of Medicaid reform, that we'll continue this conversation throughout the contracting period, the RFP process to get to the contracts, and once things are on the ground about what are the most important things for people.
Do you have any other tips and advice for how people with disabilities and their family members can make a difference in the system?
I think the most important thing that people can do is to be aware, know what's happening in the system, and voice their opinions. I am very proud of our administration. Since I've been in government, it's been 3 years, is that's been a value that has been consistent since we've been here, is that North Carolina citizens know best about what we can do in North Carolina to improve our systems. We don't always get it right, and that's never going to happen. But if you're not speaking out, if you're not meeting with public officials, if you're not meeting with legislators, telling folks what are the most important things that we can do to support you, and give us answers, give us solutions that you have, then we won't have the opportunity to make the changes that are most important. I have been so humbled by some of the stories that we've heard from people across the state, understand the impact that Medicaid and other parts of our service system have on their lives, and know that we can't do everything. But we can prioritize. We can make sure that when we do things that don't cause undue burden on people, but rather increase the opportunities for folks. And I think together, if we're listening to people, if we're hearing what people have to say, both in the legislative branch and administrative branch, then we will make the system better. It probably never happens fast enough, but it absolutely will change the way we do business. So tell your story, let people know exactly what's happening in your life. If you have answers which would make it better, very specific things, tell us that, because sometimes the obvious we miss. It might be something that's simple to change, but we're spending so much time thinking about system issues and other things, we'll miss that. And if you can think about things that are, certainly there are lots of things that cost money that we have to do, but there are things that don't, that we could change, that make the system so much better for people. And if you can bring those ideas to us too, it will also help. So.